Good morning, everyone. Again, um, we're now going to talk about the hard work and the theory behind it, which is how we assess case reports. We'll start off with single case reports. We'll do a workshop on those. Then we'll do case series and do a workshop on those. And then we'll put it all together as dealing with signals. So to start off with, we call it the logic of causality because we need to apply reasoning, and it's not always straightforward. I want you to imagine that I'm walking down the side of a house. Here's the side of a house. Along the front is the door and the windows. And as I walk along, I see a boy here throwing a stone. And I hear a crash. And I look forward, and there's the glass on the floor and some angry people. And some people saying to the boy, "You broke the window." And I think, yes, he did. I saw him throw the stone and I heard the glass break. Did the boy break the window when he threw the stone? Well, obviously you think no because I've asked you. What are other explanations? Yes, that's very possible. Any others? Yes? No, no. There might have been another boy I couldn't see throwing stones as well. Maybe the boy was too small to throw the stone that far. That's my grandson. Although somebody said maybe he could, looking at him. And then maybe the stone was just small and it wouldn't have broken the window. And as you said, maybe someone got frustrated and threw something from the inside. So it's just an example of how we think about suspected drug reactions. So, and there are just all the things we talked about. But what about the drug? Our question is, did the drug do it? And the answers are sometimes yes. Sometimes yes, but only in certain circumstances when the patient has risk factors. The answer might be yes because it interacted with another medicine. No, because it was another drug that was prescribed with it. No, it was due to the patient's disease. Or no, that drug couldn't possibly cause that reaction. Many of us know that this is phocomelia, limb reduction defects caused by thalidomide, and really why National Pharmacovigilance Centres started. But is this a perfect causal relationship? When you look at that boy, do you say that is how he is because his mother took thalidomide during pregnancy? Full stop, no other reason. We now know that some children who were born to mothers who took thalidomide during pregnancy have now had babies of their own with the same problem. And that's because even if their mothers hadn't taken thalidomide, they would still have had this abnormality because there is a background incidence. It's very rare, but it can occur without a drug causing it. So it's almost never a perfect causal relationship. So we need to have some systems because in the times when Dr. Bradley was talking about, when we had very early in looking at adverse drug reactions, when people gave a case history to different physicians, they would often come up with different answers as to whether this was an adverse reaction or not. And so it was thought that perhaps we needed to have some logical methods for us all to use so that we could increase our agreement more. Even with them, we don't always agree, and we might see that later on as we do our workshops. But they do help. They definitely help to focus our thinking. And the first one I want to talk about is the WHO UMC system for standardizing case causality assessment. It's widely used, and I've given you the website where you can find it, and I've also given you a hard copy. The categories are certain, probable, possible, unlikely, unclassifiable or conditional, and unclassified. So we'll talk about each one of them. Certain is a classification we very rarely use because of the reason I've just said. It has to be an event or laboratory test abnormality with a plausible time relationship to drug intake. It can't be explained by disease or other drugs. The response to withdrawal is plausible pharmacologically and pathologically. The event is definitive pharmacologically or phenomenologically. That is an objective and specific medical disorder or a recognized pharmacological phenomenon. Re-challenge is satisfactory if necessary. Well, I read that and I thought, goodness me, what does that mean when I first read it? What do all those words actually mean? So I thought I'd go through and try to think of explanations. Plausible, believable, it could happen, it's not impossible. So if you take a drug in the last week of pregnancy, it will not cause problems with the limbs because the limbs are already developed. So it's not plausible. And we'll look later at different times to onset to different disorders to show what's plausible and what's not. Also, the response to withdrawal is plausible. If a report says this patient had urticaria after ibuprofen, and they send the report 6 months later, and they say, we stopped the drug, they got better, but you don't know when they got better. You need to know they got better quite quickly from that sort of reaction. But others might take longer, like a hepatitis reaction or the toxic epidermal necrolysis we've talked about yesterday and today. They may take longer to recover. So that has to be believable as well. Pharmacologically, well, we say they should fit with the known pharmacological actions of the drug. But we know that that is supporting evidence if it does, but it may not, because we might not be aware of that action. We could never have predicted that the fluoroquinolone antibiotics like ciprofloxacin would cause tendinitis and tendon rupture. We just we're not aware of that at all. So this is a difficult definition, and it means that when you get something unexpected, you would very rarely classify it as certain, because you're thinking about, well, how could it do that? But things that do fit are warfarin, increasing the INR, that's its direct pharmacological action. Morphine, with its secondary actions of respiratory depression, decreased consciousness, pinpoint pupils. And amiodarone, which builds up in the tissues. They're pharmacological actions that we know about, and anything like that would fit. Pathological. Now, this is a really important thing, because if you're going to classify something as certain, it needs to have something that you can observe or measure. So if you've got definite evidence of hepatitis or tendinitis, then that's an observable clinical condition. It's pathological. If a patient says, every time I take that drug I get a headache or I feel tired, we don't normally classify those as certain because they're very non-specific, and those things come and go, and it's a little bit difficult to really put a certain tag on them. And then phenomenologically, well, what's a phenomenon? A phenomenon is something like the northern lights, the aurora borealis that you see in the sky at night, this wonderful display. Something you can see. It's a phenomenon. So it's an objective and specific disorder. And examples would be anaphylaxis. In the case of certain, that you have the immediate onset, no other explanations, and often caused by chemicals, including drugs. Things like agranulocytosis we talked about yesterday. If there's a reasonable time to onset and no other explanations, it often is drug-induced. So those are the sorts of things we're thinking about. Now, there is another aspect of certain. Do you know what these are? Well, imagine how they'd feel if they were passing down your ureter with all those spiky bits on them. They're renal stones. And you can see why they're spiky, because under the microscope they're crystalline. This patient's renal stones, and I do have to thank Pia Kadov-Janosa for this picture, were 80% ritonavir. The patient was already predisposed to forming renal stones, and the drug built on this predisposition, and the drugs formed 80% of the stones as it crystallized out in the urine. Now, the next question is, we haven't talked about rechallenge. Do you need a rechallenge in this case? No. And so there are a few cases that can be certain even without a rechallenge, just a very few. But mostly, to be certain, you need a rechallenge. And that's one of the main reasons that we don't usually classify something as certain, because often it's not ethical to rechallenge, because the reaction was serious, or it may be serious next time. For example, you might have a mild urticaria and a little bit of lip swelling with one dose of a medicine. The next dose, they get a full anaphylactic reaction. So rechallenging is often not a good idea. So that's certain. And then we go to probable. So this is a little less stringent, but it's still quite stringent. And so we have, again, an event or laboratory test abnormality with a reasonable time relationship to drug intake. It's unlikely to be attributed to disease or other drugs. You've looked very carefully. The response to withdrawal is clinically reasonable. If you have those things, then you don't need a rechallenge. It can be classified as probable. Then we look at possible. We have the same thing. We have an event or a laboratory test abnormality with reasonable time relationship to drug intake. If the report says that it started before you started the drug, then obviously it's not reasonable. It could also be explained by disease or other drugs. So you look at the report and you say, yes, they're taking this drug, and it looks from the time relationship that it might have caused the problem, but actually they were taking this other drug that we know can cause that adverse reaction. So either of them could have done it. Or we know that the patient's disease could have caused this problem. For example, we have a lot of problems looking at pancreatic cancer in patients with diabetes, because we know diabetes can cause it. And then we start looking at the drugs, and can some of them cause it? And it gets complicated. And then it may be that you don't have any information on what happened when the drug was stopped. So in that case, you say, well, there's a reasonable time relationship. It makes sense. But we've got other explanations. We don't know what happened when they stopped it. Also, there are some cases where stopping the drug doesn't lead to recovery. Maybe it was so serious the patient died. Maybe it was an interaction with an oral contraceptive that caused the patient to become pregnant. If you stop the drug, they won't stop being pregnant. So those are difficult too. So sometimes it's not just because they didn't give you the information, it's because you can't get that sort of information from that reaction. And then we have unlikely, so that it may be that you look at the event and you say, well, it doesn't make much sense. They took the drug last week, 3 years ago for a week, and they're saying that this event happened now. That's usually unlikely, and apart from some very rare cases. Or they took the drug they had the event, the symptoms were starting before they took the drug. And again, there may be disease or other drugs that provide a more likely explanation, and then we would put that as unlikely. Sadly, we get quite a lot of reports that really have very little information in them, and they need more information. And we, for example, we might have reports that say the patient took the drug on an unknown date. They had this event on an unknown date. We don't even know if the event occurred before or after the drug. We suspect it occurred afterwards because they reported it, but we can't be sure. So we say these are conditional or unclassified. And the final one is unclassifiable, when we know we're not going to get any more information and it still is insufficient. So that's the WHO UMC criteria that have been developed over the years. Now, another way of looking at assessing causality is, rather than using these categories that you reflect on and think about the elements within them, you have algorithms. And the Naranjo one is one that's very widely used. Can you just raise your hands if you use the Naranjo algorithm in your center? Right, so some of you do. Who uses the WHO UMC one? Right, okay. So when we do our exercises, we'll get you to look at both. So the Naranjo algorithm is made up of elements which you give plus or negative or no scores to. So at the end you have scores that give you the same similar categories to the one we've just, the WHO one. And these include some elements like previous conclusive reports on this reaction. Obviously, if this is something completely new, you would have to say no. But it's not negative if you say no, it's just that you don't get any scores for it. And then we have the questions we had before, like the time relationship, de-challenge, re-challenge. Are there alternative causes? What about, now then, but Naranjo is often used in drug trials, so then you start to say, did the reaction appear when a placebo was given? Well, normally that won't be in your reports. Usually blood levels aren't measured, although they may be. And then also you can look for a dose-response relationship, which is important. And has the patient had a similar reaction before? And did you have some objective evidence to confirm the event? So that's what we talked about yesterday, is being sure about the diagnosis. And with Naranjo, you can say that very high scores are definite, 5 to 8 are probable, 1 to 4 are possible, and 1 or less are doubtful, or what we called unlikely. I'm just going to give an example. Yesterday we talked about interstitial nephritis, which is an inflammation in the kidneys, in the tissue between the functioning parts. So you have the glomeruli and the tubules and the blood vessels, and they're packed in this interstitial tissue, and it becomes, some people develop this naturally, but it's one of the typical drug reactions as well, and the interstitium becomes inflamed and therefore swollen, and therefore the functional elements in the kidney are compromised, and you get renal failure. And this was identified with omeprazole and then other proton pump inhibitors in recent years. It's probably an immunological reaction, because often you see eosinophils in the urine, and it would therefore, and the incidence is about 1 in 12,000 patients, but we see a lot of it because omeprazole and other proton pump inhibitors are so widely used. But it probably would fall into the category of a type B reaction. Some patients have an immunological response to the drug that causes this reaction, which most patients don't have. Here we've got a 76-year-old female. She was taking a standard dose of 20 milligrams daily, which she took for 4 months. She was taking diltiazem and bendrafluozide, and the report said she had interstitial nephritis, poor appetite and fatigue. And that developed 3 months after she started the medicine. She continued her other medicines, stopped the omeprazole, and she recovered. Now, that is a nice clear report, except as we said yesterday, if this was a new medicine, you might want to know. Is this working? Oh, sorry, that's right. If it's a new medicine, you might want to go, or you have other concerns, you might want to go back to the reporter and say, well, how did you make the diagnosis? And then we have a 68-year-old male, And again, the same dose of omeprazole. He took it for 5 months and developed the same disorder. He was also on azathioprine, which he continued, and after he stopped the medicine, he hadn't recovered. So that's the other one was probable, this one was possible. But there are pitfalls. This is making some feedback noise. Is it all right? That better? Right. Pitfalls where you might fall down. Here is a patient who was taking 40 milligrams daily. After a month, she developed interstitial nephritis. She was not taking other medicines. Outcome not recovered. D-challenge unknown. Rechallenge reaction recurred. Is that certain? We don't have the definite diagnosis, but let's assume that you've accepted that it is interstitial nephritis. You've got recurrence on rechallenge. I would be reluctant to make this a certain report. Why is that? Yes, there's no evidence they recovered on D-challenge. In fact, the outcome said they weren't recovered. These are real case reports, and that's how they sometimes look. So be very cautious with that. So we have reports recording recurrence on rechallenge with no dates and no evidence of recovery after the first infusion, in first administration. Be wary of duplicates. Look very carefully at your reports. In our centre, we had 3 reports of inflammation in the eye with etanercept, a TNF inhibitor. And I was in a child, and I was very concerned. But I found that the initial pediatrician had reported it to us, the rheumatologist had reported it to the company and to us, and so we had 3 reports of the same event. Also be wary of reports with only one medicine. Wow. Sorry. Often it's true. But if you look at what's going on with the patient and what they have and what their diseases are, sometimes it's really unlikely that they were only taking that one medicine. So be careful with that as well. And there's more. A female patient, age unknown, was prescribed omeprazole. The dose, date of administration, indication were unknown. On an unknown date, they developed interstitial nephritis. No concomitant medicines were reported, no medical history was reported. The patient recovered on an unknown date. If you're building up evidence, you've got a report, but it's not going to give you any more information whatsoever. And you have to really make that unclassified. You also have reports, often from drug companies, where they don't really distinguish which were current medicines, which were past medicines, which were medicines that were started after the event. And so you get a list. This one had 58 with 2 suspect medicines and no dates. And then you have ones with lots of adverse reaction terms, which when you look at them are probably the whole of the patient's medical history. So just be wary of those reports as well. And here we have a 55-year-old male patient. This was a real report to me. The suspect medicine was an iodinated contrast agent. He was having an angiogram of his coronary arteries because he'd had a myocardial infarction the previous day. He received the contrast agent on the same day as he developed the rash, but it didn't say when he developed the rash, whether it was immediately or later in the day. That was all I had. What do you think about that? What happens to patients who get admitted with myocardial infarction? How are they treated? Well, they get anticoagulants, they get a beta blocker, they may get morphine for the pain, they get aspirin, they get a whole host of things. the following day, it's very likely he was still taking them. And how did I know that the rash wasn't to something started the day before? So I asked the reporter, who was a hospital pharmacist who are really good at answering. He was already on aspirin, simvastatin and metformin. He then had his heart attack, and enoxaparin, clopidogrel and metoprolol were added the day before his angiogram, and so that was the background. If the patient had had an immediate reaction as the contrast agent was being administered, I'd be much more inclined to think it was the contrast agent. But given that it was sometime during the day, it could have been any of those medicines he started the day before. So what can causality assessment do? It can classify the relationship. It can mark individual case reports that are key reports. And it can improve the scientific evaluation by systematic use of available data. It can decrease the disagreement between assessors, and you hope that that leads them all to being right rather than all to being wrong. And then what you can't do is prove the connection between the drug and the event. Okay. So, are there any questions?
Regarding the re-challenge, if it is not ethical, why do we use it?
Sorry?
If it is not ethical, why
do we use it?
Yeah.
It is ethical sometimes. Well, sometimes you find that you have data on re-challenge because somebody gave it to the person again by accident. They didn't know they'd had the reaction before, and so, or they didn't know that the event they had before was related to the medicine, and so they only worked it out when they got the medicine again. So that can happen without you actually doing it yourself. The other times are when you want to say, is this patient allergic to this medicine? And you say you give some anesthetic agents, and you give several at the same time, and the patient has a major anaphylactic reaction, then you want to know which one it is. So the anaesthetists then do skin testing. So it's not officially a re-challenge because it's not the same dose and the same route and so on, but it is a re-challenge really, because you can give tiny doses and see if the patient, which medicine the patient reacts to. So then it's ethical because it means you don't have to avoid all the general anesthetics. You can, if they need one, you can decide which they shouldn't have. Any other situations? I'm not sure. Can anyone else want to contribute?
I just want to clarify what is the main difference between conditional unclassified and the unaccessible unclassifiable. Can it be lumped into only unclassifiable, we have very limited information?
It's what we say is unclassified is where there is insufficient information, but we're trying to get more. We can try to get more information. When we say unclassifiable, it means we've asked for more information and we can't get it and the case is closed. So that's the only difference. We don't use it very often, the unclassifiable. Yeah.
Thank you, Dr. Savage, for the presentation so far. I just have a question that I was asked in my pharmacovigilance center last year concerning by one of our causality assessment assessors. The question is in relation to certain, probable, and possible. The first bullet point under certain states plausible time relationship.
Yes.
And then if you look at probable and possible, you have a reasonable time relationship.
Yes.
So I was asked a question by one of our smart assessors, and he said the definition for plausible in the Merriam-Webster dictionary is reasonable and believable. And if you look at the Oxford dictionary, it also says reasonable and probable. But then, if you look at the definition for plausible, it's saying reasonable.
Yes.
You get the point. But then for certain, you have plausible time relationship. For probable and possible, we have reasonable time relationship. So I want you to help me with a practical scenario or a practical experience to differentiate between plausible time and reasonable time. Because when you look at the Naranjo, back in Sierra Leone, we use Naranjo in the academic setting.
Yes.
And in the National Center where I work, we use the WHO.
Yes.
So if we want to distinguish, look at the fine difference between plausible and reasonable, will you give me practical scenarios?
Well, it's interesting you've brought it up, and I'm thinking, I hope I didn't make a mistake. I think it is plausible in certain and reasonable in the others, but some of them have them in the blue folders I gave you. Can you just look at the WHO Centre? I think with plausible, it's believable, whereas for the other categories, you might say for certain you might have more knowledge. You might say it fits in with the half-life of the medicine. If it's a type A sort of reaction, it fits in with our those sorts, it fits in with how long we know this sort of disorder takes to develop after you give a drug. Whereas the others, reasonable just means it's not silly. Like it's not that the event occurred before you started the medicine, or it was a very long time after you took the medicine for 1 week. It's within reason, but you don't need to know as much about the drug. Whereas for certain, you would say it's believable because I know these characteristics of the drug or the event, and I think that's a reasonable time that it would take to happen, and again, for it to improve. Can someone like Pia or Thomas or someone else improve on that?
Maybe one comment that you might not like to hear. But, of course, we have these categories: certain, probable, possible, unlikely. But when we do a causality assessment, we always take into consideration what we know about the drug, what we know about the environment of the drug, so other drugs that can be related, and what we know about the patient in the report and the story in the report. That's what other people have called the extrinsic and the intrinsic imputability. Now, what we know about the drug changes over time. So does, as it is intrinsic part of our causality assessment, at the end, our causality assessment can change over time. The usual common example that I give is ACE inhibitors and the dry cough. When we received at the national centers I was working for some 15 years ago, the first reports on patients coughing when taking ACE inhibitors, they all were classified as unlikely in terms of causality, these reports. Then later on, when we progressed and we discovered that actually what ACE inhibitors can do is a microedema of the respiratory tract and of other mucosae, then we started going into possible to probable. And now we have seen, and we can document that with CT scans, that actually there is a swelling of the mucosa, even in the gut, causing people to have a picture like an acute abdomen, and they go for surgery and they don't find anything. But if you discontinue the ACE inhibitor, then the patients get well without surgery. So the point I'm trying to make is that our causality assessment changes over time because our knowledge of the drug and the drug use changes over time. So honestly, as nice as it is on paper to make the distinction between probable and possible, in practice, it is not that important.
Mm. Yeah, those two are often interchangeable. But I'll just say one thing. Do put in your databases all your reports, even if they're unlikely or unclassifiable, because later you may go back to them, as Pia said, because you have more evidence and then they become. My first report of omeprazole and hypocalcemia, I classified as unlikely, I think. And then we saw that they cause low magnesium that leads to low calcium, and eventually we brought those reports out again and they were evidence. Sorry, you had a question. I think we'll make that the last one, and then I'll tell you what we're going to do next.
Thank you for the presentation. Thank you for the presentation. I had just 2 questions. It's great to standardize a process for interpretations globally, but there are inherent deficiencies in the process in interpreting the data. For example, though we ask for concomitant drugs, but the interpretation for drugs in different parts of the world, like herbal medicine or home remedies is one, which may not get captured depending on the understanding of the reporter. And secondly, the social practices, which are also an important factor to consider for causality. So what I see basically is an inherent divergence between pharmacovigilance and public health. So pharmacovigilance is just tailored towards knowing whether the drug or that chemical caused the event, which is great, but at some point we need to marry with public health, which is more bothered about what happened to the person or the community and how its reaction can be managed. Because when we do the report causality and we come to a conclusion, it is, let's say, related or unrelated.
Well, if I
that
can,
has to be married at some point.
we will marry them as we go through the day, because that's exactly what Pia's going to do in her signal detection and what action do you take and so on. And adverse drug reactions are a public health issue because they happen so often. They're like one of the non-communicable diseases. But now we're going to have a break. But before that, I'll just say, everybody who hasn't picked up a blue folder, they're over there. Not my big one, but one of the others. Don't start the case histories till we come back. We just want you to have a go. But we'll tell you how we're going to do it when we return. But we will have some ways of looking at probable, certain. These climbers have reached the top of the mountain. Probable, they're well equipped and they know how to climb up snow. Possible, not so well equipped, only on the grass, but possibly she could reach the top of the mountain. Unlikely, and unclassified.
Thank you very much, Ruth. Now, I would like us all